2018 entitled Recommendations to Expand, Diversify, and Improve Minnesota's Direct Care and Support Workforce. They provided key recommendations on how best to address the direct care crisis, yet the shortage gap still continues to deepen. So what we have in front of you, it's time to really build upon the lessons learned. Senators, Senate File 1062 builds upon those, specifically the direct care recommendations report. This report provide this tiered credential options and career ladders for direct care and support professionals. Looking at it, a tiered credential options and career ladders for direct and support professionals. I repeated that because I think it's important as we look at that, because when you look at the Metropolitan Center for Independent Living, they've been working for many years on just that thing. And they want to bring that curriculum to the direct care workforce, and then gets to a credentialing of a certified direct support professional, which elevates the workforce that we know today. Senate File 1062 calls for the Commissioner of Human Services to establishing a 3-year direct support professional certification pilot project in partnership with the Commissioner of Office of Higher Education. So Senator Fata is involved with that. Anoka County, Dakota County, the Metropolitan Centers for Independent Living, and the Office of Higher Ed. And then I'll also get to the other willing post-secondary institutions to implement a direct support curriculum that leads to the credential of certified direct support professionals. Project calls for scholarships to support the job seekers, direct care workers, family members, and people who rely upon the direct care service, and college students to complete the educational program that leads to this new credential of certified direct support professional. This project seeks to place those certified direct support professionals across Minnesota's direct care services for individuals with disabilities and older adults. Did I tell you we still have 53,000 job openings in that bucket? Furthermore, Senate File 1062 calls for the creation of the continuity of the educational programming and those accreditation criteria that gives us guidance to other post-secondary institutions who wish to develop and implement a direct support professional program. The Metropolitan Center for Independent Living, in cooperation with the Commissioner of Human Services and local pilot counties, will facilitate the coordination among the post-secondary institutes that are located within the pilot county. So as we look at Anoka County, where did he run to? Anoka County's we have 3 right there in our backyard. So I do, members, this is stuff that we started again. If you look at it, 2018, the conversation happened, MCIL started putting together, and now we're asking for that next level to try to address the fact of these 53,000 job openings. So I want to introduce Jesse Bethke Gomez. Of course, he's been around for a while. And actually, there's a good history there, Jesse. Executive Director of Metropolitan Center for Independent Living. You want to testify on behalf of Senate File 1062, and then you want to address the other folks you have here with you, Jesse. So there you go.
All right, Mr. Gomez, please introduce yourself for the committee, and you may begin.
Thank you. My name is Jesse Bethke Gomez. I'm the Executive Director of Metropolitan Center for Independent Living. MCIL has been involved with the direct care workforce shortage crisis ever since 2016. And we were asked to help support those committees, to bring materials from previous meetings. We're part of a cross-section group that was asked by Olmsted between Department of Human Services and Department of Employment and Economic Development to bring forth that report. I was one of the 3 technical writers for that report. MCIL raised funds to work on the project. Where over a number of years we brought forward what that certification needs to be, so it would be in line to meet the needs for all too. I want to also be mindful of time and allow our testifiers to also present. We're excited about the project, what it means for Minnesota, and most importantly, whereas the certified nursing assistant project is there for the medical model, we need the certified direct support professional for the direct care, for all of the direct care lines of service. Here to help testify on our behalf is Todd Kemery, National Director, Paralyzed Veterans of America of Minnesota Chapter, and an MCIL board member. Todd Kemery.
Mr. Kemery, welcome to the committee. Please introduce yourself. You may begin your testimony.
Thank you very much, committee members, Chair. So, Paralyzed Veterans of America is the hat I'll wear today. I also am, as mentioned before, I am part of the board of MCIL, Metropolitan Council for Independent Living. The exciting thing about this certification pilot project is that our National Veteran Service Organization headquarters in Washington, D.C. is looking and will be looking to support this as this pilot project becomes known. Not only National Paralyzed Veterans of America, but the national leaders at the Veterans Administration, D.C., are ultimately looking to the success of this as a model for the rest of the country. So the pilot program is here in Minnesota, but ultimately in the future, this pilot program will be the working model for the rest of the country. Currently, if you are in the healthcare system with the Veterans Administration, getting health care at home is a challenge. The VA only allows, and at the most, 3 days a week, 2 hours of visit. More commonly, we have chapter members that have home health care visits every other week for 2 hours. Also, we have chapter members where their spouses had to quit their job and be a full-time caregiver, relying on the system to be able to afford to be able to do that. These are things this pilot program will help eliminate, is that uncertainty, or that, if you will, a jigsaw puzzle approach to having home health care. We all know that it's cheaper to have somebody stay out of a long-term care facility or to be put in a wing somewhere. Here at the VA, there is no long-term care facility. We rely on the state for that. But there are different, like CLC, the Spinal Cord Injury Center. As a stopgap, people will stay there. That's not a solution. That's just a stopgap. So it's exciting to be able to see the VA and our veteran service organizations look to this program to be the answer for 24/7 home health care. A little bit about myself. I am a Marine. I am part of the Paralyzed Veterans of America. The unique thing about our veteran service organization is that not only do we take care of or legislate or support our veterans, but from the very beginning of our inception, we also are part of the disability community as a whole. So our legislative efforts, one of the prime examples of, other than that, being part of the Minnesota Centers for Independent Living or Centers for Independent Living, these are programs that Paralyzed Veterans of America are part of, and that's part of our mission.
Thank you. Oh, I'm sorry. Did I interrupt you?
No, that was it.
Okay.
We,
Mr. Gomez.
Two more items. We have Kate Caldwell, who has a few short words, and then Dr. Burnett as well. Kate, would you like to go ahead, please?
Dr. Caldwell, if you'd like to come on camera and come off mute, you may introduce yourself for the committee and begin your testimony.
Oh, thank you so much. Is the audio working okay?
It's working great. Thank you.
Perfect. Chair and members of the committee, thank you so much for this opportunity to testify today. My name is Dr. Kate Caldwell. I'm Director of Research and Policy for Northwestern Law's Center on Racial and Disability Justice. This bill will establish a certified personal care assistant program, ensuring standardized training, equitable compensation, and long-term workforce stability through data collection and evaluation. For over 2 decades, Minnesota, and indeed the entire United States, has faced a growing shortage of direct care workers, leaving people with disabilities and older adults without essential services. This crisis has been exacerbated by low wages, lack of career mobility, and high turnover rates. Indeed, Minnesota ranked 24th out of 51 states on the Direct Care Workforce Index, in large part due to inadequate training standards. Demand for home health and personal assistance services is expected to grow by 33% between 2020 and 2030, compared to an 8% growth rate over all occupations. 63% of PCAs in Minnesota only work part-time, and only 57% have access to employer-sponsored health insurance. The turnover rate for direct care workers is 44%, creating service gaps that jeopardize independent living. And 29% of people with disabilities who rely on personal assistance services report unmet needs, and that rises to 50% for those who live on their own. In short, the direct care workforce is shrinking just as demand is about to skyrocket. The workforce shortage does not just impact individual workers, it puts at risk the health, safety, and independence of thousands of Minnesotans. There are two primary types of direct care workers: certified nursing assistants, or CNAs, who provide personal and medical support and who follow a medical model approach primarily in institutional and healthcare settings. Then there are personal care assistants, or PCAs, who assist with daily living activities in home and community-based settings and who follow an independent living model approach. Both of these professions perform essential, skilled work, yet they are treated vastly differently. CNAs benefit from structured certification, career advancement opportunities, and regulated wage standards. PCAs, on the other hand, lack a standardized certification process, have lower wages overall, and receive little recognition, despite often providing the same level of hands-on essential care. Creating a clear pathway to PCA certification will enhance the professionalism, performance, and quality of services provided by direct care workers. Pay inequity is the single biggest driver of direct care workforce shortages. PCAs provide essential skilled support, yet they continue to be paid significantly less than CNAs performing comparable work. For example, CNAs earn a median wage of $17.19 an hour, while PCAs earn just $14.51 an hour. Now, that's the median wage. There are many who earn much less than that. And this creates, on average, an annual pay gap of $5,580 a year, despite similar levels of responsibility. Furthermore, 40% of direct care workers rely upon public assistance programs, highlighting the financial insecurity caused by low wages. The pay disparity discourages new workers from entering the field and forces many experienced PCAs to leave for better paying jobs, sometimes becoming CNAs. Senate File 1062 would ensure that certified PCAs are paid commensurate with CNAs, recognizing the value of their work and promoting workforce retention. One of the biggest barriers to long-term solutions in the direct care sector is the lack of comprehensive workforce data. Without reliable workforce data, policymakers cannot make informed decisions about wages, training, and retention strategies. I know I'm speaking to the choir here. Establishment of an independent accrediting body here would help to track workforce trends, including employment rates, wages, retention, and turnover. Also collect longitudinal data on certified PCA outcomes, ensuring ongoing program improvements, and also standardized training and credentialing to maintain consistency in care and in care quality across the state. This data-driven approach will allow Minnesota to refine policies over time, ensure that direct care workforce solutions are effective, sustainable, and very importantly, scalable. Minnesota, at the end of the day, has a huge opportunity here to lead the nation in solving the direct care workforce crisis. Senate File 1062 does not just offer short-term relief, which is what a lot of other states are trying to do. Instead, it lays the foundation for a stable, professionalized workforce that can sustain Minnesota's growing need for home and community-based services through recognizing PCAs as skilled professionals through certification and career advancement, through ensuring certified PCAs earn fair wages equal to their CNA counterparts, for strengthening workforce planning through ongoing data collection and evaluation, and finally, by prioritizing quality care and independent living for people with disabilities and older adults. This is a critical opportunity to strengthen Minnesota's healthcare infrastructure, support direct care workers, and protect the rights of people with disabilities and older adults to live independently. Thank you so much.
Thank you, Dr. Caldwell. And finally, we have Dr. Berndt.
Yes, thank you.
Please introduce yourself for the committee. You may begin your testimony.
Thank you, Chairman Queer, committee members. At Inver Hills and DCTC, our mission is to provide opportunities for students to uplift themselves, their families, and their communities. We do that work in partnership with employers, with secondary schools, with government agencies and nonprofit institutions. This pilot project represents an outstanding opportunity for us to work together to meet an acute need in our communities while creating the pathway to gainful employment. The 3-year pilot, as designed, makes sense. The scope of it is manageable, and we already have strong regional connections to launch this work and assess its potential to scale up. As a member of the Minnesota State Colleges and Universities system, of 22 colleges, 7 universities, we're well positioned to bring this curriculum to communities across the state. So thank you.
Thank you so much. Members, questions? Senator Gruenhagen.
Oh, thank you, Madam Chair. Yeah, it sounds like a good program. The thing is, you know where we're at financially, right? Okay. And, you know, one of the things I served on a school board. Really? If you didn't remember that. For 16 years, and because of declining enrollment, we wound up in statutory operating debt.
Yeah, I remember that.
So we did get to a consensus, finally, that when we had a new program that was supposed to be so good and benefit so many people that we had to put it onto the pile, right? Something had to drop off the bottom to pay for it, okay? I mean, we just cannot keep piling on, regardless of how good it sounds. So, you know, if I chaired this committee, I would make people bringing a bill forward that costs money, which evidently this one does. They would have to not only articulate the benefits, which I believe this is a pretty good program, to tell you the truth, my initial thought. I would also require that in our financial situation, where do we reduce? Now, I have a number of areas we could, if you'd want to hear that, but you probably don't. But I think that would be extremely valuable, because otherwise, a lot of these bills, in the end, when we have to make the very tough decisions, are just going to be pushed to the side because of their cost. So any thoughts on that?
Senator Hoffman.
Jesse, it's okay. So thank you, Madam Chair. And so Glenn, what we've done in this committee is we've laid out what the needs are. This is a prime example. We knew years ago, if you look back, that this bill and the next bill, actually the conversation started in 2016, right? And there's 3 of us on this committee, Senator Wickland, Senator Udke, myself, Senator Abeler, 4 of us actually that were originally part of these conversations. What are we going to do with this impending workforce need that's out there? So what we're doing in this committee, Glenn, is we're still addressing the need. We know the needs. We need other people to see that, right? Yeah, it's going to cost a lot of money. We know that, right? God bless you for bringing that up. We need to show the priority of this Minnesota is the need. If we really cared about our most vulnerable, our people with disabilities and our aging, then we would say, this makes sense. So we told Jesse, and the department is even involved with some of this conversation too. They have another thing through their CFSS conversations too. So there's multiple systems that are approaching there. And so I think we're at the point, you know, we were given the $1.5 billion whatever, and saying, okay, so you are assuming that 4 years from now we're going to be at X. Well, we're all not knowing what that X number is, right? In true case, Glenn, but in this case, we're saying, but we still have needs out there. So then it's up for you and I to go convince other people, let's address these needs, because remember at the beginning when I said there's 53,000 job openings? These are caregiver buckets. A prime example of this, Madam Chair, in Glenn's backyard, and this really hurt when Sanford Health called me and said they're going to have to close the Arlington facility. I was blown away, and you know why they had to close it? Because they could not compete financially against the cities. And this is Arlington. It's like, how far is Arlington from the cities, Glenn? An hour?
65 miles.
Yeah. And you think, oh my God, this is how much it's affecting. And these are our most vulnerable people. So, no, I hear you, Glenn, on the side of that, you know, what are you going to take off the bottom line? But in human services, we have made a conscious decision to say, these are valuable, these are life-giving, life-saving services in here. And this pilot, we think this pilot, in conjunction with what even at the department is doing in CFSS, starting in Anoka and Dakota County, we think that there's some good things here. So thank you for bringing that piece up, but I think that's basically, we're gonna lay this thing over, Glenn, and I mean, I'm with you, and I think we're all in the same boat. We have a need, so go ahead.
Thank you, Senator Hoffman. Senator Gruenhagen.
Oh, thank you. Yeah, and you and I agree on, I think, about 99% or 98%, well, maybe 90%. No, no. It's still quite a bit, okay?
It's good.
But, you know, I'll just give you one.
Yeah.
And this comes from an insider that has given me information. The HMOs that run medical assistance, and I won't name them, but you know who they are, they self-audit. That's like you go to the IRS and tell them, I'm going to self-audit my income tax return, okay? No, they're handling millions and billions of dollars. And according to this information, I don't know if you remember back, I think it was in 2011 or 12, we threatened to audit them, and all of a sudden, UCare, I think, if my memory serves me, coughed up $20 million that it came back to the general fund. I think if we would take an approach of doing an actual audit of these HMOs, we might find millions of dollars of savings that we could do these programs and other great programs to help our most vulnerable.
Thank you.
But if we only emphasize adding to the pile, we never get to
Thank you, Glenn.
looking
Senator.
at what the existing spending is.
Thank you, Senator Gruenhagen. I appreciate that. Senator Hoffman?
I think, Madam Chair, I think Glenn has just volunteered to go find some more savings. You brought up one the other day. Utke brought up one the other day. You know, when we were doing that, we're all having the
Yes.
same comment. That's what I love about this committee. So,
Senator Hoffman, I have several $100 million worth of corporate tax exemptions we could repeal. That would pay for a lot of this.
there we go.
Yeah.
Nope.
All right.
I love this.
Do you have
I
closing
love
remarks,
this
Senator
committee. You know
Hoffman?
that? I think we just want to lay this one over, Madam Chair, because there's still some work going on. And to that point, please, Madam Chair, if we can just lay 1062 over and then go to 1418. And I think Jesse's staying up here with that one, too.
Sounds great. Senate File 1062 is laid over for possible inclusion in a future omnibus bill, and we will move to Senate File 1418. Senator Hoffman?
Thank you, Madam Chair and members, and thank you for the conversation. You know, as we really look at the Human Services Disability Division, they started in 2016. Utke and Wicklund, this goes back to us in 2016 having this conversation about the growing concern for the direct care worker shortage for people with disabilities and older adults. And those area planning efforts ultimately led to an action. There was a formation of this cross-agency direct care and support workforce shortage working group. That's a mouthful. That the Minnesota Department of Employment and Economic Development and Disability Service Division at the Department of Human Services put together. The working group was in charge, and Jesse, you did about the Olmsted Subcabinet, which, you know, for members that don't know, in 1998, the Supreme Court said that people with disabilities made it Supreme Court decision. People with disabilities have a right to live in the community, right to work in the community, right to do. There was a whole bunch of rights in there, right? So we look at that. Minnesota, it took 16 years to put together this Olmsted Subcabinet. And then in 2018, there was this approved this subcommittee, and then Jesse Gomez continued to be part of it. There was a 38-member direct care working group that was hosted by the Disability Services Division at the Department of Human Services. And what you have, because of that group, just like you have at Senate File 1062, what we have in front of you is Senate File 1418. So this is years of work that was put in that. And what it really does is it just directs this 21-member committee in the Department of Human Services and the others that were involved that they have to keep working on the process, right? The availability of direct support services in all areas of the state. And so that's what we're going to do there. And Jesse.
All right, Mr. Gomez, please introduce yourself for the committee. You may begin your testimony.
Thank you so much. Jesse Bethke Gomez, the Executive Director of Metropolitan Center for Independent Living. I'm super grateful to Director Heidi Hamilton, the Director of the Disability Services Division. Once we had the report out, that committee kept meeting. We have literally volunteered ever since then to meet, to say, how can we bring forth our best ideas? I'm grateful to share with you, thanks to your support, we were able to institute the PCA College Service Corps. And during that time, we were working with over 26 colleges and universities. what we discovered is the power of post-secondary education as a way to harness that power. When we looked at all the various statutes on recruitment and retention for all the direct line services for people with disabilities and older adults, what we discovered is that it is at the agency level. What this group says is that let's look at the direct care workforce shortage gap for all of Minnesota's direct care services, for all people with disabilities, for all older adults, and put forward a plan that says here is how we're going to marshal our best foot forward. Now, one thing we should note is that today there are more older adults than the last 4 decades combined, but that number almost doubles well into the 2030s and 2040s. So the issue is, how are we going to transform our economy so that we have more direct care workers paying taxes? We have people who are no longer being forced out of their homes into long-term costly care settings. So this really helps us to get out ahead of that so that we're bringing the best what we have forward and also leading the nation in ways that we can. I'll turn that over to Senator Hoffman.
So
Senator Hoffman?
thank you, Jesse, and thank you, Madam Chair. And this goes back, as I said, this one started Abeler in 2016. You remember you initiated this. This was yours, and so we're now at that point where they had their recommendations and what they want to go forward on. So with that, I think, Madam Chair, is that I move that Senate File 1418 be recommended to pass and be re-referred to State and Local Government Committee.
Great member discussion on the bill.
Oh, sorry.
All right. Senator Hoffman moves Senate File 1418 be recommended to pass to the State and Local Government Committee. All those in favor say aye.
Aye.
All those opposed? All right, Senate File 1418 is headed to State and Local Gov.
Thank you, Madam Chair and members. Thank you, Jesse.
Thank you. Senator Abeler, Senate File 1827. No, to Hoffman. He's coming back, isn't he? All right, Senator Abeler, Senate File 1827. You may begin when you're ready. And I see you have a testifier, but how many listed? Do I need to add a testifier?
He's an unlisted testifier.
Technical
He's
assistance?
There's an amendment too.
Oh, there's an amendment as well.
We have 2 amendments on this.
Senator Abeler, would you like to move your amendment before you begin?
Are we doing the A? This one? Yep. We're doing both of them.
Oh, I see it.
Remove the sections.
Is this one that's a delete?
Senator Abeler, would you like to move the A1 amendment?
The A1? Okay, yeah, I'd like to move the A1. The bill's too long, Madam Chair, and it should be shorter. And there's another one? Oh, it's not in the packets? Oh, okay.
Oh.
It's not in the packets, Madam Chair.
It's not in the
There's
package.
just confusion if we should do it here. This bill has, the bottom line for this bill is it's going to go to, we're taking some things out, and it's going to a judiciary as almost a judiciary-only bill. So.
Okay. Well, we will.
Mr. Monahan tried to communicate with me, and I was not communicating back to him.
That's okay. Senator Abeler, we will get the A something amendment passed out.
The A1.
It's the A1 amendment? Okay.
I talked to the door on.
Yeah, it's in, okay. So Senator Abeler, would you like to move the A1 amendment before speaking to your bill?
I would like to move the A1 amendment.
All right, Senator Abeler moves the A1. This is an author's amendment. All those in favor say aye. Aye. All those opposed? The A1 amendment is adopted. Senator Abeler to Senate File 1827.
Madam Chair, I'll let my non-testifier comment on what we just did.
Please introduce yourself for the committee, and you may begin your testimony.
Thank you, Madam Chair. My name is Brian Zerbas. I'm the Executive Director of March, a statewide trade association. The 2 sections of 1827 I'll be giving an overview of. In Section 1 is making changes to Minnesota Statute 169A, specifically on line 2.8. What the intent of this bill is to do is when a court or when someone gets a driving offense, the court may refer them to get an assessment, chemical dependency or a substance use disorder assessment. And what we're wanting to do in lines 2.8 is to clarify that if someone has income eligibility for medical assistance or the behavioral health fund, that person should not be paying the provider directly for the assessment because there's already an existing funding mechanism for the program to get paid for that assessment. So we're seeing that as a barrier that we'd like to remove. Sections 2 and 3 via the amendment are being removed. And then the last piece in Section 4 is instructions to the reviser. The term chemical dependency is an outdated term. So in working with Senate Council on identifying instructions to the revisor to update the language. I know our hope is to continue working with Department of Public Safety and Human Services on what language should be changed in that statute.
Thank you, Mr. Zerbis. And Senator Abeler, is there a fiscal note for this bill?
We have I'm phoning a friend.
Okay.
Madam Chair, I did request a fiscal note on the underlying bill, although not on the A1 amendment. I did confirm with the departments that the costs, I believe, were driven by what was just removed in the A1 amendment. The only question I'd have, I may have to check with our Judiciary and Public Safety fiscal analyst regarding whether the first subdivision would create a cost, but I wouldn't expect that.
Thank you. Senator Abeler, any?
No, and Madam Chair, if there's any costs between public safety and here, we'd have to do it, otherwise it's a nice piece of paper. So this is going to go to Judiciary, so if you want me to move that it go, recommended to pass and go to Judiciary as amended, unless people have more questions.
Yeah, let's, members, any more questions, any additional questions, conversation about the bill?
And I'm open to a list Senator Clark.
Senator
and
Abeler?
Senators Clark and Umo were beaten, so I don't have to go to Judiciary. So.
Wonderful. All right, Senator Abeler moves that Senate File 1827 as amended be recommended to pass and get sent to the Judiciary Committee. All those in favor say aye. Aye. All those opposed? Senate File 1827 is on its way to Judiciary, Senator Abeler. You may stay at the table. It looks like we have Senate File 1966. Great year, I hear.
Well, thank you, Madam Chair, and this is another important bill for March. And just rather than me saying it, I've got a testifier here who can give you all the details. Thank you. And other testifiers, too.
Mr. Beltowski? I got really close.
Oh, yeah,
Please
this-
introduce yourself for the committee and, or no, sorry, Mr. Zerbis.
Yeah. let him-
Okay, please introduce yourself for the committee. You may begin your testimony.
Thank you, Madam Chair. Committee members, Brian Zerbis with March. So Senate File 1966 has 4 parts. The first section is related to timely filing requirements to reset the clock when there's a clawback with a managed care organization with the provider. There's written testimony was sent to committee members by a handful of our members, noting some of the problematic experiences they have when this happens with a payer. Section 2 is regarding program closure requirements for recovery community organizations. What it would do is mirror the requirements existing already in Section 245A, Human Services Licensing Act, which would require a recovery community organization to notify clients ahead of a program closure, help refer them to the next program, and then also inform them of how they can access their medical records in the future time to come. Section 3 is regarding timeline requirements for diagnostic assessments. For certain substance disorder programs, get a rate enhancement for having what's called co-occurring enhancement. Those programs, when they screen someone with a mental health screen, that screen is positive, they're required to do a diagnostic assessment within 10 days. What we're wanting to do is add in language that would say it would to exclude weekends and holidays. The reason for that, some of our smaller programs and rural programs do not have mental health professionals staffed on weekends and holidays, so that adding that language would give them a little bit of extra time to stay in compliance. The last piece, or section 4, is on withdrawal management, county financial responsibility. And the language we have in there pointing to Minnesota Statute 256G would say that the county of financial responsibility for withdrawal management is the county of residence. And to that point, we have another testifier.
Okay, Mr. Beltowski, would you like to introduce yourself for the committee, and you may begin your testimony.
Good afternoon, Madam Chair, members of the committee. Thank you for the opportunity to speak today. My name is Mike Beltowski. I'm the former Vice President of Operations for Gateway Recovery Centers, 2 withdrawal management programs, the current Vice President of Program Development for Horowitz Health, and the Treasurer of March. I'm here to recommend the necessary clarification of the County of Financial Responsibility for withdrawal management services. I'm excited that the state has advanced detoxification by incorporating clinical and medical services to ensure adequate care for all. However, to fully address and ensure equitable access, we must update the CFR definition for withdrawal management. Currently, detox CFR is based on the county where individuals are present when the need for services arise. However, withdrawal management is both a commercial and Medicaid-covered benefit that has traditionally followed the social services definition, including alignment with the behavioral health fund applications. Despite detox and withdrawal management often being used interchangeably, they are distinct services, each requiring clear financial responsibility to ensure sustainable service delivery. To address this, and in collaboration with the Maxa Behavioral Health Group, we propose the statutory update to clarify CFR for withdrawal management, as the county of financial responsibility for withdrawal management services is defined in section 256G.02 subdivision 4. This ensures counties can support individuals when no other funding source is available. This update aligns with public policy intent 245F.01, which emphasizes equitable access to medically appropriate services regardless of an individual's ability to pay. This update does not remove the obligation to pursue available funding options, but it provides critical financial structure for counties and providers alike. By defining CFR separately for detox and withdrawal management, we create a clear, consistent framework that promotes financial stability while ensuring continued access to care for vulnerable Minnesotans. While this does not represent a drastic shift today, it provides long-term protection and strengthens the collaborative relationship between providers and our counties. I urge your support for this update to ensure Minnesota's withdrawal management services remain accessible, sustainable, and responsive to our community's needs. Thank you.
Thank you. Senator Abeler,
We'll stand for questions.
thank you so much. Members, questions for Senator Abeler or the testifiers? Mr. Senator Hoffman.
Thank you, Madam Chair. And Senator Abeler, maybe we can talk about this after you're done with both 1827 and 1966. Brian, you're going to still be here in the next one. Yeah, I have concerns about something that is going to be happening in the next 60 days when we're talking about substance use, and maybe it's a larger conversation, especially a treatment provider that is housing issues going on. And, what are we going to do? Is there some, all hands on deck on something like that? And I just thought of that because you were talking about treatment provisions, modifications, and maybe Brian, you can talk. Is there plans in place that March, maybe think about that as March and other providers thinking about how they're going to help support those people that are not? And I know it's away from your bill, but it's in the same theme. So, Senator Abeler.
Miss.
We can wait till we talk about that.
Okay. Great.
Thank you. Sorry, Madam Chair.
Still your committee, Senator Hoffman.
Your committee right now.
Members,
Madam
any
Chair, I
other?
like your
Senator Abeler. It's a real coup now. Senator Abeler, any?
Yeah, just some closing comments.
go
I want to
ahead.
point out why some people don't want to serve on this committee. Just kudos to the staff. It's not their fault, but it takes 5 pages to change 4 words. Anyway, so if you look at the bill, most of the pages are no changes. So there's not a fiscal note, Madam Chair, and I imagine we're laying this over. Is that right? No. Is it going somewhere?
Yeah, Senator Abeler, I think you wanted to send this to judiciary and then worry about a fiscal note between here and then?
That's the other one.
Yep,
This one, too?
you're right. Please hold.
Oh, we're at 66. I'm sorry. No, that goes to commerce. Sorry, I'm sorry, Madam Chair.
Oh, commerce.
Recommended to pass and be referred to commerce and consumer protection. Is that what you're?
And Mr.
Senator Abeler.
whoever, Madam Chair, the heck with. Senator Hoffman, Madam Chair. And I think that the reason it's going is because of Section 1, which there's going to be some discussions to try to sort that out.
Okay.
And so that's why we didn't testify much about it here. It's in the works and on its way to commerce. So
Okay.
I'll have to find
Senator
somebody in
Abeler.
Commerce to co-author this for me, so I don't have to go there either. So.
Senator Abeler, my only, I really like your bill, and I was actually just talking with a mental health provider about recoupment times and submission times. Apparently, they have 30 days to submit a claim, but the insurance company can come back and recoup literally any time, like in perpetuity, which seems wild. Are these sections of law pertinent to that? Because if so, I might have some amendments for you for commerce.
Do you know the recruitment thing?
Mr. Zerbis.
Yeah, can we maybe talk about it?
Well, just briefly. Well, I don't know, she just had a question.
Yeah, Chair, question, Madam Chair. It certainly is a major impact on programs, particularly when clawbacks happen outside of the timely filing window beyond 1 year. I think in written testimony from, that was submitted to some members, the issue that happens when the clawback happens outside of the timely filing, the program is kind of left in the dark. They have the ability to try to go after the next plan, but because it's outside the timely filing window, that creates more administrative barriers to pursue that. And frankly, a lot of programs don't pursue it because the time and money they spend trying to get reimbursed on something is a waste.
Thank you for sharing that. Yes, I've heard just, and it's not, these aren't like corporate providers. They're just, providers who are trying to provide care to people and yeah, and then they're up against corporations who have time immemorial to find ways to claw back. So if there's adjustments we could make in this bill to limit that, I would be more than open to it. But that's not this committee and that's not this specific bill. Senator Abeler?
So, Madam Chair, thanks. So we'll sort that out. If nothing else, the rest of the bill is in good shape to go with some omnibus somewhere. So with that, I'll move that the Senate File 1826 be recommended pass and be sent off to Commerce.
All right, Senator
No,
Abeler.
wrong bill. No, 1966. Sorry.
Yes, Senator
1966.
Abeler moves that Senate File 1966 be recommended to pass to the Commerce Committee. All those in favor say aye. Aye. All those opposed? All right, Senator Abeler, you are on your way to the Commerce Committee. But you're staying at the table for Senate File 1826.
Thank you, Madam Chair. And I think the highlight of this 1826 is that Mr. Monahan gets to recodify stuff again. So he is amazing at that. There's more content than that. So I'll let Mr. Zerbis talk about that.
Mr. Zerbis, you may begin your testimony.
Thank you, Madam Chair. Committee members, on Senate File 1826, so starting in Section 1, I think as Senator Abeler had mentioned, we'd worked with Liam Monahan quite a bit on this one. Section 1 is cleaning up some language to allow, some of the proposals in the rate changes to happen. Section 2 is implementing the substance use disorder rate recommendations that were in the outpatient rate study introduced to this body last January. Section 3 has an automatic inflation adjustment. Again, the thought around that is once the modeled rates for SUD services are attained, the idea of having an automatic inflation adjustment annually to avoid this kind of long gap of rates being stagnant and getting behind. Section 4 is removing the term SUD from a mental health reimbursement section, and worked with Senate Council on that. And then all of Article 2 is a recodification of SUD and conforming changes recommended by Senate Council.
Thank you, Mr. Zerbis. Senator Abeler, you have
We have
three other testifiers. So
Yeah.
Roy John Sutherland and Lou Zeidner, if you want to come to the,
And Madam Chair, just to offer a
Sorry,
caveat,
Abeler.
this bill spends a little bit of money. And so I understand the budget pretty well, but I do counsel individuals and groups that to come and say what they wish could be. If there was an area to put some money, this would be actually a really good place to do it. So for that, I'll take on my testifiers.
all right. Roy John Sutherland, please introduce yourself for the committee and you may begin.
Thank you, Madam Chair. My name is Dr. Roy John Sutherland. I'm the Vice President of Addiction Services for Neisterman Associates, a licensed psychologist, a licensed alcohol drug counselor, and I'm an elected member of the March Board of Governors. Neisterman Associates has over 60 locations specializing in psychiatry, therapy, and addiction services. Of our 60 locations, we have 31 outpatient and 1 residential SUD program. Last year, within SUD, we served 8,400 unique patients, resulting in 108 encounters. We provided services for both adults and adolescents. For over a decade, there has been numerous rate studies. In most recent study by Burns and Associates, cost-based rates were specifically looked at. The conclusion of the study identified 8 of 9 rates that were underfunded, resulting in recommendations of an average increase of 68% to remain financially viable. As a result of this, the gross underfunded industry of over 47 programs in the past 3 years have closed statewide. Again, that's 47 programs. For over 14 years, the industry has seen nominal increases in outpatient reimbursement rates, resulting in providers being stretched to do more with less. We are all about efficiency and reducing costs. However, providing outstanding services does come at a cost. Our industry is at a breaking point where increased salaries and benefits, a reduced workforce, and regulatory requirements put significant strain on providers and organizations like mine. It's difficult to provide life-saving programs when the cost is outpacing the revenue coming in. Our staff-to-patient ratios have increased, providers are tired, and they're leaving the field for careers that do not include as much emotional strain, allows for life-work balance, while also paying them more to support their families. This is also of a grave concern to me, as I am someone who's dedicated my career to helping people live better lives and strengthen their future. Now, let's talk about the benefits. According to the literature, the investment in mental health and addiction is well worth the upfront costs. The following are some of those benefits. Lower healthcare costs. Early intervention prevents severe conditions that require expensive emergency care and hospitalization. Our emergency rooms are full of patients. Lower suicide rates. Access to mental health and addiction care reduces the risk of suicide, which has both an emotional and economic consequence. Reduces the spread of infectious diseases, as substance abuse is sometimes associated with a link of spreading of diseases like HIV and hepatitis. Stronger families and communities. Mental health and addiction treatment helps individuals maintain stable relationships, reduces domestic violence, child neglect, and reduces criminal activity. Ultimately, the studies have shown that for every $1 invested in mental health and addiction treatment, society gains 4 to 7 in economic returns through reduced healthcare costs, increased productivity, and lower crime rates. In conclusion, investing in addiction services is not just a compassionate choice, it's a financially sound and strategic investment that leads to healthier individuals, stronger economies, and safer communities. The long-term societal benefit far outweighs the initial costs of increased reimbursement rates. Please pass SF 1826, seeking to implement increased SUD rates from Burns & Associates at 100% of the model rates with annual automatic inflation adjustments. Thank you, Madam Chair and committee members.
Thank you, Dr. Sutherland. Lou Zeidner, please introduce yourself for the committee. If I'm missing a doctor or some sort of title in there, let me know, and then you may begin your testimony.
Thank you, Madam Chair, members. My name is Dr. Lou Zeidner, and I serve as the CEO of EOSIS, formerly known as Meridian Behavioral Health. EOSIS has been providing substance use disorder and co-occurring mental health care to patients throughout the state of Minnesota for over 25 years. We have 13 residential and 7 outpatient programs from East Grand Forks to Owatonna, from Stillwater to Waverly. We represent about 25% of the Medicaid beds for these services in the state. In the 15 years since 2011, when the state began setting Medicaid rates for SUD services, residential SUD reimbursement rates have only been increased by $39 per day, or 15.7%, while labor rates during the same period have increased by 49%. This has resulted in financial losses that have led to a breaking point and will result in our closure of sites of care, particularly in rural areas of the state, if the rates are not increased. These closures will result in huge gaps in services with a significant impact on rural and Twin Cities Minnesotans alike. Last year, the state's independent consulting group, HMA Burns, reported on the results from their extensive analysis of cost and rates for residential SUD services in Minnesota. And that study started in 2021 and concluded that Minnesota's rates were over 58% below what was required for sustainability of services. These results were 3 to 4 years in collection, and each year represents an increased gap above the 58%. Minnesota's very low reimbursement rates for Medicaid for substance use disorders impacts EOSIS in two ways. Our labor costs, lease rates, food costs, et cetera, continue to escalate, while our revenues from Medicaid that represent 90% of the care we provide has remained stagnant. Our labor rates are increasing because qualified clinicians and support staff are able to be paid significantly more by systems that are primarily serve commercial insurance patients. And similarly, they are pulled across our borders in cities like Moorhead and East Grand Forks to North Dakota, where the Medicaid rates are twice Minnesotans and salaries are $15,000 a year higher. We recognize that the legislature has many priorities to address and that available monies are tight. Nonetheless, if we do not receive material relief in the form of rate increases and a path to sustained rate increases, we will be forced to close many of our programs with a resulting crisis of access to care in multiple communities across the state. Effective treatment for substance use and mental health disorders reduces downstream costs in medical care, corrections, and general community challenges. We urge the committee to support this bill, including rate increases for the residential substance use and related care. Thank you.
Thank you, Dr. Zeidner. And then Sadie Brokemeyer, I have you on Zoom. If you'd like to come on camera, come off mute, introduce yourself for the committee, you may begin your testimony.
Hello. Thank you guys for letting me attend virtually. I am representing the Minnesota Alliance of Rural Addiction Treatment Programs, or MERITAP, which represents our rural program. So I'm a little bit further outside the cities. But my name is Sadie Brockmeyer, and I'm here testifying today as a member of MERITAP, which is a 501c nonprofit organization that seeks to bring together diverse rural interests to address and advocate for strong addiction treatment programs throughout Greater Minnesota. Formed in 2017, MERITAP advocates for legislation and policies that strengthen the health and well-being of rural Minnesotans and improves rural access to higher quality, lower cost health care. And I'm here today to provide MERITAP strong support for the Senate File 1826 and the importance of the significant investment in the state's substance use disorder treatment infrastructure. As you have heard, the Department of Human Services 2024 rate study confirmed what we already knew in the field and have known for years, but it really highlighted how large the gap is between medical assistance reimbursement and the cost of providing quality substance use disorder treatment. I like to highlight here in Kanabec County, which is where Recovering Hope is located, we're one treatment provider in the entire county. And within our 5 county areas, there's no adolescent treatment, whether it's outpatient or residential, because programs have been closing. And it slowly started to happen with the one other provider here in Kanabec County, followed by their location in Pine County, and just to continue to hear the small rural providers struggle. And the gap is particularly noticeable for programs like Recovering Hope Treatment Center in Mora and the several rural communities where the overwhelming majority of our clients are covered by medical assistance or the Behavioral Health Fund. Without private health insurance to supplement our operating revenues, we rely almost entirely on the rates established by the legislator. And when those rates lag behind, we're unable to recruit and retain clinical staff in our rural communities, and we struggle to keep our doors open or providing additional care. We recently at Recovering Hope have posted for a drug and alcohol counselor and been turned down by 2 really amazing individuals because we aren't able to compete with the metro salaries and the larger organizations that are able to offer some of those higher paid salaries at the metro rates. The rate increases contained in the Senate File 1826 are absolutely vital to ensuring the long-term viability of our rural treatment infrastructure. I also wanted to highlight what Dr. Sutherland said about the cost benefits. And I want to highlight that Recovering Hope serves women, women and children, and pregnant women. We're one of 4 residential programs that takes third trimester pregnant women and has a unfunded by the state daycare center for a residential program. And we save the state even more money when it comes to child protection cases, out of home placement, emergency room visits, and neonatal care for babies born that have been born with substance use disorder mothers. And so I just wanted to highlight that as well. And thank you guys for the opportunity to testify this afternoon. And I'm happy to answer any questions here. If you want to reach out to me, I'm always willing to share my thoughts.
Thank you, Ms. Brookmeyer. Members, any questions? Senator Gruenhagen.
Oh, thank you, Madam Chair. Yeah, I appreciate you working with addiction, okay? I did jail ministry for 13 years, so I saw a lot of it. Anyway, if you were to break down the addiction by categories of the patients you have, what do you see as a major contributor to promoting addiction? I mean, is it fentanyl? Is it illegal drugs? Or what percentage do you see of addiction walking in the doors? Alcohol, or what is it?
Doctors Zeidner or Sutherland? Dr. Zeidner? Or Dr. You know what? Senator Abeler, you decide.
Once you start.
So most recently, we actually looked at some of these statistics. Alcohol still is the major substance that is abused the most. Then we're seeing a large increase of methamphetamines, and then we have opioids, I would say, in that order. And then you'll see some of the stimulants like cocaine, but it's mainly those 3.
Dr. Zeidner, would you like to add?
Thank you, Madam Chair, committee members. So I would just add that THC is also becoming a greater prominence, particularly in our adolescent population, but alcohol remains the primary area of responsibility.
Senator Gruenhagen?
Oh, thank you. Thank you, Madam Chair. Yeah, THC would be marijuana, right?
Correct.
Yeah. See, one of the things we've done in Minnesota, unfortunately, is we began legalizing addiction. And then you people get to pick up the consequences on it. You know, one of the things we did last session, or the session before, when we legalized the sale of marijuana, we greatly reduced the consequences to selling to minor children, which is probably the most susceptible that once they're addicted to break. And again, because I've worked with these people just on a non-professional basis, just on a ministry basis when I went in there, they always let me out every Sunday night, fortunately. You know, one of the things you begin to understand is that that a lot of these people are addicted at a young age, and they will do anything to feed that addiction. I'm sure you're aware of that. They'll steal, they'll rob from their own family members, they'll do whatever, they'll sell themselves into prostitution, whatever it takes to feed the addiction. And unfortunately, in Minnesota, it seems like we've gone down the road to legalize some of this stuff, or at least greatly reduce the consequences. So if you have any recommendations in those areas to tighten things up, I'd appreciate it. Do you have a response?
Dr. Sutherland?
Thank you, Madam Chair. Just to kind of respond to that, so we know substance use disorder is a way for people to avoid chronic mental health and medical conditions. So, for example, I specialize in the treatment of PTSD. It's something I'm very passionate about. And, you
Dr.
know,
Sutherland,
not only
will you repeat that?
I specialize in the
The
treatment
first
of PTSD.
part about what generally drives addiction.
So it's mental health and medical conditions. But one of those mental health conditions is the experience of trauma. And so when that results into PTSD, a great way to avoid is using substances. And so not only is addiction services grossly underfunded, but so is mental health. And so our industry is really struggling to find these experts in PTSD and mental health because they're choosing other fields. They're burnt out, they're tired. And so in order to get these people into our field and treat all of these patients who have these histories of trauma, which are no fault of their own, we really have to increase reimbursement rates so they can make a living and invest in these patients. And so if we want to help our community, we got to treat the mental health and we have to treat the addiction because they go hand in hand.
Thank you, Dr. Sutherland. Senator Hoffman.
Thank you, Madam Chair. Thank you, Dr. Sutherland. You just said it. That intersectional conversation must occur. Is that correct? You would agree with that?
Dr. Sutherland.
Thank you, Mr. Chair Hoffman. Yes, you have to treat mental health and addiction. However, each of the different disciplines, be it an LADC or a mental health professional, have their role in that treatment. And so it's important for us to take a look at this because it not only impacts the mind, it also then impacts the body. If we treat mental health, we know that mental health and general medical visits into our hospitals and healthcare systems reduce substantially. That is cost savings. And personally, I know this because my spouse works in the ED at Abbott, and he talks about all of the patients coming in and how they have a hard time getting all of these patients through the emergency room. People are sitting in hallways. I mean, that's not compassionate care. We need to invest.
Yeah.
Thank you, Madam Chair.
Thank you, Senator Hoffman. Any other? Oh, Senator Rasmussen. Thank you.
Thank you, Madam Chair. I was wondering for our providers, what's the average age that when you're working with your patients that they first are experiencing issues with substance use disorder?
Dr. Zeidner.
Thank you, Madam Chair and members. We are seeing people who started in their early teens. It sometimes takes years before they get to a place where they get treatment. But oftentimes they're starting in their middle school.
Senator Rasmussen.
Thank you, Madam Chair, and thank you. I think that's just, shows how important this work is too with our K-12 education system and just everything we're doing. If, these issues are starting when people are in their adolescence, I think it's just important we have a coordinated approach.
Thank you, Senator Rasmussen. I want to thank you all for coming and in particular talking about, my follow-up question to Senator Rasmussen's would be, if you're digging down into the trauma, when are most people experiencing the trauma that originate? I mean, it's a lot of escapism, it's avoidance. Where are we seeing that originate from? Dr. Sutherland, then Dr. Zeidner.
Madam Chair, what we know is most people experience a traumatic event in their lifetime. Most people, though, have a natural recovery. We see about 3.5% of people be diagnosed with PTSD, lifetime's about 7.5%. But those people end up using a lot of the resources out there because they avoid so much. They tend, and I saw this all the time when I worked at the VA as a licensed psychologist on the front line. These individuals avoid and they use substances. And so we know that if you treat the PTSD and you treat the substance use at the same time, these people get better and they get better fast. And that impacts families. I mean, I grew up on a rural hog farm in northern Minnesota. My dad was a part of the military and the Air Force. I know about avoidance because my dad worked nonstop in the Iron Range mines or on the hog farm. And it impacts the entire family. Now, I'm not saying that that he necessarily had PTSD, but I'll note that he saw a lot. And so I think it's important for us to invest in our future, and it really comes down to all of you to help the citizens of Minnesota.
Dr. Seidner?
Thank you, Madam Chair and members. You know, I think the question about when trauma happens is often very variable for people, but I think part of what happens is when there's access challenges, the trauma repeats itself. And so I worked for 15 years in emergency departments across the state, and the experience of someone coming in, whether intoxicated or in other challenges, and experiencing an emergency department, often for hours at a time, waiting, and some of that trauma just continues to perpetuate the experience of I'm not worthy. And part of what we need to look at is access to care. Many of our patients, they're not having troubles with substance use because they're bad people. I think it's easy to dismiss this as good people don't have problems and bad people have problems. Most of our patients started with an opiate problem because they had a back strain or they had a leg injury. They got started with their doctor prescribing the medication. They took it as directed, and over time that became an addiction and became more problematic. Similarly with alcohol, it is very rare that you go to a social event where alcohol is not a prominent part of how you engage. And so for the 15% or so of people who are going to develop an addiction with alcohol, they start off in a very normal way and it becomes problematic. So I just want to make sure that the committee understands that this is not about good people and bad people. This is not about problem people and non-problem people. This is about receptivity to the disease.
Thank you for that. For this Senate File 1826, is it staying in this committee? Yeah. Okay. Senator Abeler, would you like to close?
Yeah, Madam Chair, I think this has been a really good discussion in the hands of an excellent facilitator, I might add.
Thank you.
Oh, sorry. Anyway, so this is a committee who cares. And just as I look forward to what's going to be happening here, Senator Wickland and Senator Hoffman, I hope having gavels at a time of a really challenging budget. But if you heard just the general takeaway here, if they're at 58% below somebody else, that's a deal. And okay, why is that important? Well, the populations we're talking about is not the Blue Cross market or the health partners market in the commercial side or the self-insured. These are the people that we're responsible for in our committee here. There's 1.4 million or so people on some kind of health care from the state and 100 and some thousand on waivers and all of that. And we're short of people anyway on the long-term care side, but this is the more treatment side with the substance use and the mental health side. And pretty soon, there's not going to be anywhere for those people to go. Already up in Kennebec County, they're worried they're down to one. Pine County's got whatever, they're losing them all over the place. And so it's a real problem. And so Senator Wickland had a bill for about $200 million for rate increases, and I signed on to that bill, especially initially. But I understand the challenge. Why would you, let's just find a way to pay. I don't have any funding source for this. It's about the same denomination. Back of the envelope, it's maybe $110 million for 2 years. And then the good news is then inflation gets taken up by the forecast. Well, actually, that's not free. And so I came in here feeling kind of good. Hey, I got 3 bills up. Let's, get judiciary, some jokes about that. But if you look at the face of who we're looking at, thanks to these 2 great clinicians that have come to just remind us about who we're trying to care for and the challenge. And I don't have an answer for that. Well, I do. It's triage and prioritization. But I think as we triage and prioritize, we'd better remember that this particular group is going to go out the back door. Just both the providers, but also the individuals. Because in the Medicaid system, Minnesota care system, we are the last resort. So that's kind of depressing, but we did all our campaigning for the privilege to sit here and try to solve these things. And I cannot, if you take this panel and the Health and Human Services panel, I can't imagine a more thoughtful bunch of people to sit there and wrestle with this. And I do believe that in the grand scheme of things, that with all respect to the Senate, I think we do have more depth in the bench just to understand this. But the House is going to have to grapple with this as well. And the governor's going to bring his budget out in a little while and forecast on Thursday and all that. So anyway, but I think this is really productive of a discussion. There's no blame going on, just me and my amazing testifiers in March, that what they do, they go and borrow money to stay in business to help people that they care about. Anyway, so that's all I got, Madam.
No, I appreciate that, Senator Abeler. I did have one question, and it was what I was thinking about before. Is so these are Medicaid, this is for Medicaid reimbursement. Would work requirements impact this for Medicaid?
Do you want to, the two clinicians want to work? So the feds are one of the ideas. They're casting about a bunch of ideas. Just to actually back up a second. So a number of us wrote a letter. We're trying to be thoughtful, please, about this whole thing. And everybody's turning to be kind of broke. So it's like, anyway. And there's a bunch of ideas floated. My best math is that the Medicaid budget's somewhere around $900 billion a year, and it's going to be growing. And so the 880, if it all comes out, is over the 10 years, maybe like 6% or something. Not inconsequential. I'm not saying it's like nothing. But amongst the list of things are suggesting work requirements. And so on the list of possible things. And so to the two clinicians, just rephrasing the question.
Yeah, no, thank you, sir. And I think
how would that impact if there was a work requirement?
it'd be for able-bodied adults with no children, I believe is the.
Yeah, okay, well.
Yeah, I think that's the, no, Senator Abeler, you gave the great background. I think it wouldn't be for children. It wouldn't be for people with children. It would be for able-bodied adults who have no children would be the work requirements for MA.
So can you comment what that would look like? Who is considered able-bodied that would meet a definition you don't know yet? And it's a fair question.
Dr. Sutherland?
Madam Chair, I'm unsure of what the work requirements necessarily would be at this time. I would have to look into them and study it and learn a little bit more. I don't know if, Lou, you can say anything to it.
Dr. Zeidner?
Madam Chair, members, I think what we need to look at in that context is not, these folks are not sitting around twiddling their thumbs because they're lazy. Okay, and I think the work requirement is a good one in general, but I think we need to make sure that if people are ill and people are struggling with an illness, that they have the ability to get their health care, and that we are able to look at that in the context of their health care. If they had a heart attack and they were in cardiac rehab, we would modulate our requirements in that context. I think we need to look at this in a similar context, not saying that work requirements are not a good thing or important, but we just need to make sure that we're understanding when people are vulnerable and when they need to have some rest in addition to the work.
Thanks for that, Senator Abeler.
I'll just have another way to rephrase the question, which maybe helps get at what you're after, because I'm curious myself. So of the individuals you serve in your program on the Medicaid side, what percentage are working, and just looking at them with totally unenlightened eyes, how many would be considered able-bodied, even though they're not well? Is that a fair question?
Dr. Sutherland.
Madam Chair, I'd have to actually look and find out what the actual statistic or the data says about that. What I would say is this: many of these individuals, these patients, are working, but they're also taking care of their children and their families. Many of them are just trying to stay alive. I mean, our suicide rates are increasing drastically, and so they're just trying to get out of bed in some ways, because this is a chronic disease, and so they're just trying to cope. But if you're looking for a statistic, that would be something that I'd have to do some research in, which I'd be happy to do.
Thank you, I appreciate that. I think mostly it's, we're just trying to get a sense of, as we move through the budget process, they're doing it federally, we're doing it in the state, we're going to get a forecast, and it's just trying to understand how the pieces go together. I'm not a personal fan of work requirements because I don't think healthcare should be tied to your job. So I just want to be really clear about that. But I appreciate, it would be helpful to get information just kind of as we move forward. And I appreciate you rephrasing the question, Senator Abeler. That's in the background, it's helpful. Senator Aki?
I just want to note that our testifier via Zoom has got a hand up.
Thank you. Ms. Brookmeyer?
I was just gonna say, one of the things that my clients do to return to work for like their MFib and their like cash assistance and the things that they use outside of the work is a return to work form. And so some of the things that we work with our clients on when they go through our program is when is that right time to return to work? And being able to work with the provider, looking at like what Dr. Sutherland talked about with mental health, and if they're in programming for 12 hours a week or 20 hours a week, and this tends to fall more on our outpatient, is being able to say, okay, let's have you look for work, or let's have you work up to 10 hours or 20 hours, or yeah, it is time for you to go back full time. Like, you're showing me these things. Let's kind of get you back into the flow so you can support yourself. While also some of those clients during that time period are looking more at the Social Security disability avenue if they're really not able to return to work. And some of that's just childcare dependent too, which I think is this committee where you guys are looking at how can we have better access and quality around daycare services to get people back to work. I tell you, I would have been there in person, but I have to pick my children up by 5 p.m. today. So that is a real life struggle. And being able to kind of navigate a lot of the things in an individualized way can be really helpful, whether it's tied or not tied or where people fall. But there are some things that we work on in treatment to get people back to work. And I have about 20 clients in our lodging program right now. And I would say I think about half of them are working. And our goal would be to have all of them work or be able to find something of substance. Because I think Dr. Sutherland said that connection and purpose are the opposite of addiction when we look at how to heal people, and we want people to feel of value, and work is one way that people can do that when they're in early recovery.
Absolutely, thank you for that. And yes, most people want to find work of meaning and contribute in that way, and so it's wonderful that you help find that. Okay, so this bill, Senate File 1826.
Madam Chair, just
Senator Abeler, please go ahead. Yep.
So my desire is that in Washington, the conversation is as thoughtful as this one was today. And you choose carefully, and, that's my desire. So I wrote the letter with the help of many friends. We have our hands full, but I think this has been an unusually thoughtful conversation. And I'm glad we had the time. I didn't even know it was going to be this cool when I got into it. I mean, painfully, but good. So thank you, Madam Chair.
Thank you, Senator Abeler. Senate File 1826 is laid over for possible inclusion in a future omnibus bill. And Senator Hoffman, would you like to talk about the bills coming up on Wednesday?
Senator Abeler, if you guys could stay there, because it's dawning on me as we were talking about just the needs out there, and thank you, Dr. Sutherland, when the question was popped out, it's like, alcohol, it's the #1 killer. I mean, it is. It really is in Minnesota, and we've known that for years. And I was surprised that it still is up there. But then all these other things are addiction is addiction is addiction is addiction. Whether it be gambling addiction, whether it be whatever it is, addiction needs to be dealt with. And thank you for your work on that. And having said that, talking to Representative Baker from the other body, Senator Abeler, and then Senator Cran just approached me too. There's a concern out there. There's people that are in addiction services right now that are going to lose their housing within 60 days, right? And nobody knows the number because apparently the organization hasn't shared that number. But I'm now having anxiety and panic attacks about these are your vulnerable individuals. And when you just struck to us about mental health and substance use, absolutely, there's the numbness, whatever it is, the body keeps the score, whatever it is that's there, that this individual and their lived experience. What are we doing? What are our contingency plans? And have you as an organization march, and you're shaking your head, Doc, and I saw Chuck Hilger running around here, Ryan's back there, Christie's over there. And Madam Chair, if it'd be okay, I mean, if just to get you guys helping us understand, what do you need from us as a committee? What do you need from us as a body? What do you need? Because at the end of the day, right, wrong, or indifferent, there are individuals with disabilities, individuals with certain needs. There are individuals that are fighting an addiction that we just can't leave on the street because Jim, do you remember the pictures when you were the chair? I mean, we let off why we do what we do. This is why we do what we do in this committee, right? And so, yeah, Madam Chair, I did want to, yeah, you got on Wednesday, but if we could have that, Jim, I don't know, this conversation, Senator Rasmussen, Senator whoever, we do. We have 5 bills up on Wednesday. I'm so fragmented because of the fact I'm really starting to feel the impact of what about those people. So can you help me out here, Brian? I mean, we need all hands on deck.
Mr. Zerbis.
Thank you.
Thank you, Madam Chair. To Senator Hoffman's question, I mean, what you're referring to is a really, really big deal in the state of Minnesota. I think that, certainly March, our executive committee, our board is meeting and discussing how we as a trade association can get involved in this. We represent about 2/3 of all the treatment programs in the state. And when there's an impact on a program, what our role is to facilitate support, how we can support clients it's vital. And this is again, it's a really big deal. What I think not only programs are looking at, but the people receiving services, their family members, the community in general. It's certainly concerning, but also I think we want to be helpful and not kind of get in the way of the work that DHS does with a license holder. That work is important, that they're working together. But what we talked about with one of the bills of program closure requirements, that there are processes in place that programs need to go through to notify their clients and work on referrals and that kind of stuff. Again, there certainly is some capacity in other programs, but the timing of any changes in impact this large is going to be very, very delicate.
So, Madam Chair.
Senator Hoffman.
Thank you. Thanks, Brian. And the other thing is that, the county and the housing, I mean, there's just so many moving pieces here. And I'm just, you're the last safety net for people that are in addiction, other than Lutheran Social Services or Catholic Charities. It's like, who else, Lou? I mean, where else do we go? What do you need from us? Or, Christie's here. Did the department, do you guys need to meet in my office right now and have a conversation? If I'm overstepping my bounds, Christie, that's fine. But I guess at this point, all I care about is the unique and individualized needs of those people in the addiction recovery that they have. So, and thank you, Senator Abeler, for letting me, but you brought these guys together. So.
Dr. Zeidner.
Madam Chair, members.
Thank you, Madam Chair.
Thank you for the question. So we are working diligently to open more slots for patients, both on an IOP, intensive outpatient, and on the residential side. There are obstacles, obviously. The staffing at DHS is a relatively slow process for licensure, and that is a rate-limiting step. Obviously, that would the more that we could speed that up, the better. But we are certainly receptive and have capacity to serve some of those patients.
Senator Hoffman.
Madam Chair, why would license, so we're in a crisis situation. Some people are not going to be having homes. They're going to die, right? Addiction's going to overcome them. They're going to be on the front page. Actually, nobody, they're not going to see it on the front page. But your statement about licensing process, this is where now you piqued my interest. Do we have a committee? Is there something that's holding up you guys for the ability for you to do your work? Why would licensing hold up a crisis? And if I'm misunderstanding that, I guess I'm like,
Dr. Zeidner.
now I'm angry.
No, Madam Chair, members, I apologize if I.
No, I'm not angry at you. I'm
Senator Hoffman.
Sorry, Madam Chair, Madam Chair and Doc. I'm not angry at you. I'm just angry because after running into senators in the hallway, and I'm hearing numbers of 1,000 or 1,700 people, all I see are people that have nowhere to go, and they're haunted by this addiction. They're numb by whatever it is their lived experience is holding them. Their trauma, like you were talking about, Sutherland, and I just can't. I'm perseverating on that word. I'm going to keep using it, and so thank you, Doc.
Dr. Zeidner and then Dr. Sutherland.
Madam Chair, members, thank you, Senator Hoffman. My intention there was we are looking to increase our outpatient spaces for patients in several of our residential sites to allow for a continuum of care. And the licensure process in that is a lengthy process. We would have more slots today if that was a faster process.
Dr. Sutherland, would you like to follow up with that?
Thanks, Madam Chair and committee members. So you asked what you can do to help. Yep. Give us reimbursement rates that make sense, that are common sense. I mean, at the end of the day, this is an investment in Minnesota families, and we're a close-knit group in the addiction services across all of our different companies. We all know each other. Half of our counselors have worked at half of the other counseling centers. The point I'm trying to make is we are going to be there for these fellow organizations the best we possibly can. However, how long are we going to be there? Without reimbursement rates and the increases in them, how are we going to be able to keep people actually in the field? I mean, my job when I go to work every day is how am I going to take care of my providers? How am I going to keep my providers satisfied, to keep them engaged, to help them create hope in their patients? And if I don't have the resources to keep them employed, then we can't help anybody. Not only will these organizations close, all the other organizations are going to have a difficult time operating too. And that goes for mental health rates. The mental health rates aren't all that great either. And we're really lacking these reimbursement rates across the board in mental health. And you're going to see increased physical and medical problems because of it. So we either invest now or we kick the can down the road, and then it's a bigger cost later on. Mm-hmm. Thank you.
Thank you, Dr. Sutherland. Do you want to turn your microphone so people can hear you? Thank you, Senator Hoffman.
So, yeah, Madam Chair, I think this, it leads to, are we as a committee, this is our jurisdiction, and we're seeing something that we've never seen in the state of Minnesota ever happen like this, where there are that potential many people, and it's like 30 or 60 days from now. But David, maybe as we look at Wednesday, when we got 5 bills up, I would like to, if somebody from the department could give us an update, and maybe Christy, I would like it to be Christy Grom, is that fair? Give us an update about the contingency plan, and then, Brian, if you're not engaged with Christy as an organization and association, I would hopefully advocate that occur. I know the county's on the housing side, Jim, it all comes down to this housing side of it, right? Anyway, Jim.
Thanks, Madam Chair and Mr. Chair.
Senator Abeler.
Thank you. So I really appreciate all that. And Senator Hoffman, I do believe you're going to be the hub of this thing, just given your role and all that, along with whomever else decides to weigh in. You're in the right place at the right time, in concert with the other chairs and so on. Sorry, you are. But actually, you're quite knowledgeable, and there is, and all that, just to encourage you. And just given the politics of the state, maybe the governor, as you work with the department, maybe there's something the government could do with executive orders or something to tide this over. I don't know that there's a lot of money available, which I would love to offer anybody, but there is policy and there is pushing and there's changing temporary licensure things, you pass a quick bill or something. And I think, but given part of why we get stuck in we're too stuck in bureaucracy. And I've written hundreds of pages of law, so I'm sorry, made it longer. 5 pages to change 4 words. But at the end, it has to work. And I think to all of us here, the Washington politics is the Washington politics. The St. Paul politics is the St. Paul politics. The House is what it is, the Senate's what it is. And with all that, people want us to make it work somehow. And so if we can encourage people to be flexible, encourage both Washington and St. Paul to be flexible with their oversight. And I think that where it slows down sometimes is the advocates be worried. Well, I think they'll be less worried if there's like no place to put 1,000 people. They'll be like a little flexible, knowing the passion and compassion we all have. But Senator Hoffman, I do believe it's going to land at your door with Senator Rasmussen and Senator McQuaid and all the rest of the members here. So anyway, but this has really been enlightening. I think, I mean, we have bills all the time, and like, oh, there's a nice bill laid over. But so actually, we got into the heart of the work behind the bill this time. And so Senator Hoffman, Senator McQuaid should chair more often. Look what this is.
Senator Hoffman.
Madam Chair, the future of this committee is sitting to the left of me, these two individuals over there. Abeler, I think what...
Welcome to the dinosaur world.
Senator Abeler.
Welcome to the world of dinosaurs.
McQuaid and
Senator
Rasmussen. I hear you and I agree with you. So Senator McQuaid, thank you, Madam Chair, for involving this conversation. I am really, I'm grateful for you and for this, so.
Senator Hoffman, you can share with the rest of the committee and the public what the remaining bills are for Wednesday, and then you should adjourn the committee.
Yes, Madam Chair, I will take the gavel back from you on bills on Wednesday. David, we got Senate File 792. We got a House Child Body Waters Care Center grant. Utke, I thought that was part of our stuff last year, but I guess we'll find out. Maybe it's an Iron Range thing where they just need, Senator House Child. It's supposed to be funny. Senate File 1810, Rasmussen. Waiver Services, out-of-state billing permissibility clarification. Senator Mohammed, Senate File 1146. You're going to be quizzed on 245D, the historical perspectives along 245D when it was actually 245H, and then et cetera. So we will absolutely. And then Senator McQuaid, the DCT Executive Board Appropriation. You guys saw the newspaper, what's happening down at our at DCT. Did you see that? You did see that? Is that something too that we should be talking about? Because I just said that because Senator Rasmussen, Senator McQuaid's got the DCT Executive Board Appropriation for planning and build out, and then Frentz, we got a Blue Earth County long-term residential city supplement. So Senator Rasmussen.
Thank you, Mr. Chair. And no, I read the, I believe it was a Star Tribune article about, issues at direct care and treatment. And I think yet another example of why we need to have a commissioner and not have a part-time board, given the challenges.
He had to get that. I didn't see that coming, Senator McQuaid, but that was good, Rasmussen. You still got a 50-50 chance in this committee to get that passed. So, I love that. That Senator Rasmussen, that was the only contentious, really, bill we had last year. I love it. So that was good. With that, Senator Rasmussen, that was awesome. We are adjourned.